Hello everyone. We are presenting a research study on outcomes of patients presenting with central nervous system tuberculosis at a tertiary care center in India. The study was conducted at SHATE VS Hospital in the city of Ahmedabad, state Gujarat, India. It was conducted from December 2015 to February 2018. The presenters of this study are Darshil Shah, who is Clinical Research Coordinator at Hackensack University Medical Center in New Jersey, United States, and myself, Chinmay Jani. I'm resident physician in Internal Medicine Department at Mount Auburn Hospital, Harvard Medical School, Cambridge, Massachusetts. Tuberculosis is a major health problem, not only in India, but the entire world. It is caused by Mycobacterium tuberculosis, which is transmitted by inhalation of aerosol droplets and mainly affects the lungs. Consequences are as mentioned in the slide. It can either lead to clearance of the organism, can lead to primary TB, latent TB, or reactivation of TB. Tuberculosis will be referred from now onwards as TB. Burden of TB in India is one of the highest in the world, as it accounts for almost one-third of the global cases. Although TB can involve almost any part of the body, some of the most important ones are the lymphatic system, bones, liver, the central nervous system, and the adrenal glands. Focusing more on our study topic, TB can involve many parts of the nervous system. In immunocompetent patients, CNS TB constitute around 1% of all tuberculosis cases and 6% of extrapulmonary TB. Most common, it is spread through blood, but other possible routes can be direct rupture or extension of a subpal or subependymal focus. Granulomatous inflammatory reactions may involve meninges, brain, the spinal cord, or even the bones covering the brain and spinal cord. CNS manifestations can be classified as following, as mentioned in our slide: tuberculous meningitis, tuberculous arachnoiditis, tuberculomas, and tuberculous abscess. Tuberculous meningitis, from now on referred to as TBM, accounts for 70 to 80% of neurological TB cases, mostly patients present with stiff neck, headache, fever, or vomiting. Tuberculous meningitis, unlike bacterial meningitis, has more subacute presentation. It can be diagnosed by incorporating clinical, radiological, and CSF criteria, which are described by Ahuja criteria. We will describe this criteria in more details on our further slides. Tuberculous arachnoiditis most commonly involves spine and particularly lumbosacral region. Patient with a history of prior TB infection or possible exposure who presents with signs and symptoms of subacute onset of nerve root compression should be suspected to have tuberculous arachnoiditis. Tuberculoma is a mass of granulation tissue which can be seen as a ring-enhancing lesion in the brain. It can be single or multiple. It can be clinically silent or can be large enough to cause symptoms of increased intracranial pressure. It can be caseating versus non-caseating. Caseating granulomas are distinctive from non-caseating ones. The non-caseatings are more homogeneously enhancing lesions. Caseating have rim enhancement. If these have a central calcific focus, they may form a target-like lesions. Current WHO guidelines for the treatment of tuberculous meningitis are 2 months of HRZE, used as a short abbreviation, for isoniazid, rifampicin, pyrazinamide, and ethambutol, which is followed by up to 10 months of rifampicin and isoniazid for all patients. In cases of CNS TB, adjunctive glucocorticoid therapy is beneficial. Glucocorticoid regimen followed is either dexamethasone or prednisone.
Hi, this is Darshil Shah. The aim of this study was to assess the in-hospital outcome based on modified Rankin scale in patients with various forms of neurological TB who received daily anti-tubercular treatment as per WHO guidelines. The objectives of the study were to study the socio-demographic, clinical, laboratory profile, and radiological spectrum of the patients, to study in-house outcome using MRS, to assess the severity of CNS tuberculosis in these patients, and to study 3-month treatment outcomes in patients with various forms of CNS tuberculosis.
Okay.
This is a prospective observational study conducted at Sheikh VS Hospital, Ahmedabad, Gujarat. The sample size for this study was 56 patients. We included the following patients: all immunocompetent patients diagnosed with CNS TB based on neuroimaging and lab findings, patients above the age of 18 years, and patients who gave informed consent. We excluded the following patients from the study: patients with Pott's spine and TB myelitis, presence of secondary immunodeficiency states such as HIV, infection, and malignancy, pregnancy and lactating mothers, and patients who were lost to follow-up. AHUJA criteria was used to diagnose TBM in our study. The criteria includes clinical examination, CSF fluid examination, radiological examination, and evidence of extraneural tuberculosis. Clinical examination involves fever, headache lasting for more than 7 days, vomiting, altered sensorium or focal neurological deficits. CSF examination includes pleocytosis, protein, and sugar, the values of which are given on the slide. The radiological examination includes CT scan of the head showing 2 or more of the following: exudates in basal cisterns or in the sylvian fissure, hydrocephalus infarcts, or meningeal enhancement. The evidence of extraneural TB includes presence of active TB in lungs, GI tract, urogenital tract, lymph nodes, or the skeleton system, which should be evidenced by appropriate radiological or microbiological tests or by presence of caseating necrosis on histopathological examination. The diagnosis of tuberculoma was made using Rajashekar criteria. It includes clinical examination, CT scan, and response to anti-tuberculous medication. Clinical examination involves presence of evidence of raised intracranial pressure with headache and vomiting and/or papilledema, presence of progressive focal neurological deficits, which can be motor or sensory, and seizures. CT scan features include the size of the lesion more than 20 millimeters, irregular shape of the lesion, or presence of midline shift. The response to the anti-tuberculous medication should be good clinical and radiological response. Several clinical evaluations and investigations were conducted throughout the study. Once the patient was eligible for the study, we collected demographics, comorbidities, nutritional status, and the neurological status of each patient. Neurological examinations included categorizing the patients based on British Medical Research Council scale for TBM, and they were also assessed based on modified Rankin scales. Both of these scales are described in the upcoming slides. The procedures which the patients underwent throughout the study were hematological and biochemical profiles. They also underwent lumbar puncture for CSF analysis and several imaging procedures. All these tests and procedures were conducted at regular intervals and also a 3-monthly follow-up, or if clinically indicated as per the PI. The following slides states the British Medical Research Council scale for TBM and the modified Rankin scoring system. The Bmrc scale consists of 3 stages. Stage 1, the patient is fully conscious with no paresis. Stage 2, the patient has decreased level of consciousness and no paresis, and stage 3, where the patient is deeply comatose with or without dense neurological deficits. This scale was used to measure the prognosis and outcomes in all patients. The modified Rankin scoring consists of scores from 0 to 6, 0 stating no symptoms at all and 6 meaning the patient died due to CNS tuberculosis. All 56 patients were categorized into Group A, B, and C based on their diagnoses. Group A consisted of patients with tuberculous meningitis. Group B, patients had tuberculous meningitis and tuberculoma, and in Group C, patients had isolated tuberculomas. Each patient underwent neurological status and functional outcome assessments on admission, during discharge, and 3 months after follow-up. All the patients with CNS TB were treated according to the WHO guidelines described before. Patients with TBM were given intravenous dexamethasone, and patients with intracranial tuberculomas were given oral prednisone, and the outcomes were defined based on the modified Rankin scale.
The results of these studies are as follows. Out of total 56 patients, 26 had tuberculous meningitis, which were part of Group A. 13 had tuberculous meningitis along with tuberculoma, forming Group B, and 17 had tuberculoma only, forming Group C. Mean population of the study was 35 with standard deviation of 11. 48% of our population, that accounts for 27 patients, were females. The age range of our population was 18 years to 65 years. We did Pearson correlation factor, which showed increasing age was associated with poor outcomes. Clinical features. The figure on the left side describes the clinical features in patients of Group A and Group B. Fever was the most common presenting symptom in Group A. Headache was present in almost 92% in patients of Group A as well as Group B. Group B patient had seizure in almost all the patients, forming 100%. Cranial nerve palsy was seen in 16% in both the groups. Neurological deficits were more in Group B with almost prevalence of 54%. In patients with Group C, all patients had seizure, followed by headache, fever, and focal neurological deficits, with their percentages mentioned in the slide. Bmrc clinical staging of illness. All patients from Group A and Group B were staged based on Bmrc scale. We have described this scale in our past slides. Majority of the patients presented at stages 2 and 3. Very few patients presented in an early stage, as described in the figure on the right. This slide describes two separate results. Regarding the duration of the symptoms, out of 56 patients, around 73% of patients had a prolonged duration of illness ranging from 2 weeks to 3 months. On a multivariate analysis, this factor was associated with significant poor outcomes with a hazard ratio of 0.35. Regarding Csf analysis, we have compared Group A and Group B in this table. As you can see, majority of the patients in both the groups had elevated protein count. Regarding lymphocyte cell count, around 31% had mild elevation in Group A and almost 70% had elevation including mild as well as severe. As described in the bottom of the table, 71% of patients who presented in stage 2 and stage 3 of illness had moderate to severe elevation of proteins, of which 23% had mild elevation, 43% had moderate, and 25.6% had severe elevation. Talking about imaging, in Group A, the most common imaging finding was meningeal enhancement, almost about 65%, followed by hydrocephalus, which was 58%. In Group B, the most common finding was 61% meningeal enhancement, followed by infarcts in 46% of patients. In our study, solitary lesions appeared to be more common than multiple lesions, as described in Table 7. Most patients with tuberculoma with or without tuberculous meningitis had supratentorial location of lesion in which parietal lobe was the most common site. We calculated modified Rankin score on admission while the patient was in hospital and on a 3-month follow-up. As you can see, it was always high in patients of Group B as compared to other groups. On comparing the outcomes on the day of admission, in the hospital after receiving some treatment, and on 3-month follow-up in each group separately, we can see that groups A and C had significant improvement at different stages. Group B also showed a trend of decreasing score, but we could not achieve significance on the analysis.
Some other outcomes which we found in our studies are active pulmonary tuberculosis was associated with poor outcome. The most significant predictors of worse outcomes in all the 3 groups in our study were cranial nerve palsy with a hazard ratio of 0.38, long duration of illness with hazard ratio of 0.35, and older age with a hazard ratio of 0.33. Also, cranial nerve 6 was the most affected cranial nerve in our study. Now let's move on with the discussion part of the study, which will be divided into several parts depending on the topics. 67% of patients in our study had TBM with or without tuberculoma. That is, they were in Group A or Group B. In our study, patients with TBM presented with several non-focal symptoms like headache and fever, with headache being the most common symptom. A similar observation was made by a study conducted by Twetis et al. Patients with tuberculoma most commonly presented with seizures, and several studies like Madhuranath and Arsani reported similar scenarios. These non-focal symptoms might not be recognized in certain rural areas due to lack of awareness, leading to a delayed diagnosis and treatment of CNS TB. A study in France concluded that a delay of 3 days between presentation and initiation of anti-tuberculous medication was associated with increased risk of death. Therefore, in such situations or in suspicious cases, increased surveillance is required. According to the Bmrc scale, patients who presented at stage 3, their prognosis was associated with almost 50% mortality, and those who recovered had some residual neurological deficits. Some patients also presented with hemiparesis and hemiplegia, that is, in 23% patients in Group A and 53% in Group B. Some studies showed that 15 to 57% patients with TBM who progressed to stage 3 had cerebral infarcts. According to Heesh and colleagues, 75% of infarcts were in the TB zone. The TB zone was supplied by medial lenticulostriate arteries and the thalamoperforating arteries. Whereas only 11% of the patients, the infarcts were in the ischemic zone. The ischemic zone is supplied by lateral lenticulostriate arteries, anterior choroidal arteries, and the thalamo-geniculate arteries. Limb weaknesses and the 6th cranial nerve involvement were also associated with poor outcomes in our study. In our study, patients reported vision impairment, that being from legal blindness to functional impairment of vision. And vision impairment was a significant predictor of poor outcome. Some other studies also associated that the vision was impaired due to optochiasmatic arachnoiditis. Some studies showed that chorioathetoid movements were also presenting manifestations of tuberculoma, and in our study, it was present in only 5% of patients. On CSF analysis, a total of 71% of patients who presented at either stage 2 or stage 3 of the illness had moderate to severe elevation of proteins. Advanced stages were associated with higher CSF protein levels, which was similar to some earlier studies. We found no correlation between the severity of the illness and CSF sugar levels in our study, which was in contrary to the study conducted by Hosoglo. To definitively diagnose tuberculous meningitis, the presence of tubercle bacilli in the CSF either by smear examination or by bacterial culture is required. Sensitivity for CSF CBNAAT, that is the nucleic acid amplification test, was sent in all patients and was found to be 41%, which is compared to 38%, 53%, and 66% in other studies which are mentioned in the slide. We found no rifampicin resistance in the study. CSF ADA was sent in 12 patients and was sensitive in 8 patients, but as standardized cutoffs are not established for CSF ADA, it is not recommended as a routine diagnostic test for CNS tuberculosis. On imaging, we found that 65% of the patients had meningeal enhancement, which was similar to a study conducted by Goyal, which showed meningeal enhancement in almost 60% of patients with TBM. Hydrocephalus is the most common CT findings for several studies. In our study, hydrocephalus was present in 51% patients, making it the second most common finding. Few noticeable outcomes of our study were as follows. Patients with isolated TBM or isolated tuberculoma had better outcomes, while patients with TBM and tuberculoma had higher percentages of poor outcomes and higher mortality rates. Our study had better outcomes in patients with tuberculoma compared to patients with TBM with or without tuberculoma. But several other studies suggested that tuberculoma had similar or worse outcomes compared to patients with TBM with or without tuberculoma. The mortality rate in our study, which is 18.6%, was similar to certain other studies who had used daily anti-tuberculous treatment regimen. We also observed that cranial nerve palsy, higher age, and longer duration of illness showed poor outcomes. Some of the limitations of our study are as follows. Since it is an observational study, we did not have control subjects to compare our outcomes. Our hospital catered to lower socioeconomic background in the western part of the country, and hence the study was not representative of the country as a whole. Due to low economic background as well as lack of electronic medical record system, we did not have fully accurate past medical history, vaccination history, or comorbidities of each patient. Pulmonary TB was diagnosed using an X-ray, even though CT scan has shown to be of higher accuracy. Despite all these limitations, our study gives us detailed information of the unique population of CNS TB in the western part of the country. It will serve as a baseline for further studies with higher sample size and matched case control study design. I will be summarizing our study in this slide. CNS TB can present with multitudes of symptoms and presentations. In our study, higher age, duration of illness, and cranial nerve palsies were associated with poor outcomes. Seizures and focal neurological deficits were present in patients with tuberculomas, whereas some non-focal signs such as headache and seizures were also seen as presenting symptoms. Patients with tuberculoma and TBM at admission had worse outcomes compared to other patients. Hence, identification and evaluation of focal signs and certain non-focal signs is very important to diagnose cranial nerve tuberculosis in highly suspicious cases. We need to increase awareness of CNS TB in certain tropical regions, which will help us to diagnose CNS tuberculosis earlier and treat it in a better way. I would like to thank all of you for taking interest in our presentation and viewing it. Below is a citation of our published article in International Journal of Community Medicine and Public Health. Please take a look. Thank you and have a nice day.